Hello and welcome to my YouTube channel. Today, the video will be on acute inflammation. So let's start the session. Inflammation. What is inflammation? Inflammation is a complex biological response of body tissues to harmful stimuli such as pathogens, damaged cells, irritants, and it is a protective response involving immune cells, blood vessels, and molecular mediators. The function of inflammation is to eliminate the cause of cell injury, clear out the necrotic cells and tissues damaged from the original insult. Inflammation is of two types, acute inflammation and chronic inflammation. Acute inflammation is the initial response of body to harmful stimuli and is a series of biochemical events involving the local vascular system, immune system, and various cells within the injured tissue. Chronic inflammation is a prolonged inflammation which leads to progressive shift in the type of cells present in the site of inflammation, such as mononuclear cells, and is characterized by simultaneous destruction and healing of tissues from the inflammatory response. Coming to causes of inflammation. The causes of inflammation can be categorized in four broad categories: physical, biological, chemical, and psychological. Physical. In physical causes, burns, frostbite, injury, foreign bodies, ionizing radiation. The biological causes could be infections and immune reactions. Chemical causes could be chemical irritants, toxins, and alcohol. And the physical causes could be excitement or stress. What are the 5 cardinal signs of acute inflammation? The 5 cardinal signs of acute inflammation are pain, heat, redness, swelling, and loss of function. In Latin, it's called dolor, calor, rubor, tumor, and functiolacia. Now, why this happens, I will be telling you in the further slide. The acute inflammation has 2 phases. One is the vascular phase and one is the cellular phase. Coming to the vascular phase of acute inflammation. In this, initially there is a transient vasoconstriction of arterioles for a few seconds, which is followed by vasodilation of arterioles and then capillaries. This increases the blood flow to the affected area, resulting in heat and redness. So 2 signs are explained here, heat and redness, which is because of the increased blood flow to the affected area. It is followed by increased permeability of local blood vessels, which allows proteins, cells, and fluids to leave the blood vessel and enter the interstitial fluid, causing swelling or tumor. The chemokines or molecular mediators also alter the blood vessels to permit the migration of leukocytes, mainly neutrophils, to flow out of the blood vessels into the tissue, which is known as extravasation. Some of the released chemokines, such as bradykinin, increase the sensitivity to pain, which leads to hyperalgesia or dolor. The loss of function is probably a result of neurological reflex in response to pain. So here I have explained all the 5 features which are actually the cardinal signs of inflammation: heat, redness, swelling, pain, and loss of function. Before explaining the vascular phase in detail, I would like to tell you about the Starling principle. The Starling principle says that the extracellular fluid movements between the blood and tissue are determined by differences in hydrostatic pressure and colloid osmotic pressure between the plasma inside the microvessels and interstitial fluid outside them. Now, as you can see here in this image, I have shown a capillary. At the arterial end of the capillary, the blood pressure is 32 mmHg, and at the venous end of the capillary, the blood pressure is 15 mm of mercury. The hydrostatic pressure is the pushing force on water due to presence of more fluid in one region than another. So here in this capillary, the capillary is having more of the fluid, which is exerting a hydrostatic pressure out to the outward. So here you can see the hydrostatic pressure is towards the outwards, and osmotic pressure is the pulling force of water due to presence of solutes or proteins in the solution. So the osmotic pressure will be always inwards because the proteins will be present inside the capillaries, and these proteins will exert an inward pressure towards inside, and these proteins will exert an inward pressure. So here in this condition, the osmotic pressure is 22 mm of mercury. Now I have explained you how the fluid shift happens between the blood and the tissues. It's regulated by the hydrostatic pressure and the osmotic pressure. So as you can see here in this image, I have shown you the normal and then the exudate and the transudate phases. So in normal, the hydrostatic pressure and the colloid osmotic pressure remains in balance and there is no leakage of fluid. However, in conditions of exudate formation, what is the underlying pathology? Actually, there is vasodilation and stasis, which leads to increased space between the endothelial spaces and it causes fluid and protein leakage. So, in exudate, there will be both fluid and protein leakage because of increased interendothelial spaces leading to exudation of the fluid and protein. In transudate, what is the underlying pathology in transudate? In transudate, there is fluid leakage, not protein leakage, just the fluid leakage, and it is because of, as you can see here, the hydrostatic pressure is increased and there is decreased colloid osmotic pressure. So whenever there is increased hydrostatic pressure and decreased colloid osmotic pressure, there is fluid leakage which will lead to formation of transudate. The transudate will always have low protein content and few cells, which in contrast with exudate, which will always have high protein content and many white blood cells and red blood cells. Let me tell you about how the vascular permeability is increased. The vascular permeability is increased because of retraction of endothelial cells, which is induced by histamines and other mediators, and this is rapid process and is short-lived. The other less common cause of increased vascular permeability is because of endothelial injury, which occurs in thermal burns or because of some microbial toxins. This is a rapid process and may be long-lived. So I have explained you the vascular events in acute inflammation. Coming to the cellular events in acute inflammation. The cellular events of acute inflammation can be categorized in 5 phases: margination, rolling, adhesion, transmigration, and chemotaxis. What happens in margination? Well, when there is stasis of circulation, the neutrophils tend to lie up along the endothelium near the injury site, and this is known as margination. Next is the rolling. When the neutrophil roll along the endothelium, sticking there intermittently, that is known as rolling. Adhesion. Following rolling, the neutrophils attach more avidly to the endothelium, and this is known as adhesion. Transmigration. When the neutrophils migrate through the blood vessel wall, this is known as transmigration. The neutrophils can leave the blood vessel through the relaxation of interendothelial cell junctions and digestion of vascular basement membrane. Chemotaxis. When the neutrophils move to the area of damage, that process is known as chemotaxis and it is mediated by chemotaxins, which include C5a, leukotriene B4 and bacterial peptides. Here in this image, I have shown you the various phases of leukocyte migration through blood vessels. So as I have told you, initially there will be rolling and this rolling is mediated by some endothelial molecules and leukocyte molecules. So on the endothelial, as you can see here in the image, there are molecules like P-selectin, E-selectin, glycam-1 and CD34. These endothelial molecules aid in rolling because the molecules present on the leukocytes, for example, the silyl-Lewis X modified protein and integrins, they mediate the rolling and adhesion, and there is leukocyte migration through blood vessels due to interaction of these molecular mediators. Now, once the leukocyte have come to the site of injury, there will be phagocytosis. So, what are the phases of phagocytosis? In phagocytosis, initially there is recognition and attachment of particle to be ingested by the phagocyte. The leukocyte gets activated and attached to the dead cells or microbe. Chemotaxis is the directional movement of phagocyte towards a chemical attractant or chemotaxins. These chemotaxins include bacterial products, example endotoxin, injured tissues, complement proteins like C3a, C4a, C5a and chemical substances produced by leukocytes, also called as leukotrienes. These chemokines or chemotaxins activate phagocyte and attract them to the target cell to mediate their effect. So, as I have told you, initially there will be recognition and attachment of the particle to be ingested by the phagocyte. How does this happen? It happens by a phenomenon known as opsonization. In opsonization, the particle which has to be ingested by the phagocyte comes near the phagocyte, and because of presence of opsonins on this particle, the phagocyte recognizes it and it gets attached to the phagocyte. After that, the phagocyte forms pseudopods, and these pseudopods actually form a phagocytic vacuole, and then the phagocytic vacuole goes and combines with the lysosome. The lysosome enzymes are secreted, which will lead to killing and degradation of the ingested material. So, remember the three phases of phagocytosis: recognition and attachment, engulfment, and killing and degradation. Phagocytosis I have again explained in this diagram. As you can see here, the microbes bind to the phagocyte receptors and the microbes are ingested in phagosome through engulfment. When the phagosome binds to the lysosome, there is formation of a phagolysosome and there is degradation of the microbes by lysosomal enzymes in phagolysosome. There are two pathways for phagocytosis. One is an oxygen independent pathway and one is an oxygen dependent pathway. In oxygen independent pathway, there is destruction of the pathogen via lysozymes. And in oxygen dependent pathway, there is generation of reactive oxygen species such as superoxide radicals and hydrogen peroxides, which kills the pathogen. Now, coming to the chemical mediators of inflammation. What are the chemical mediators of inflammation? Well, the chemical mediators of inflammation are those substances which are either derived from the cell or plasma, and they are very important in acute inflammation. So let me tell you about these chemical mediators. The cell-derived chemical mediators of inflammation can be of two types, either preformed or synthesized de novo. The preformed chemical mediators are histamine and serotonin, and the chemical mediators which are synthesized de novo are arachidonic acid metabolites like prostaglandins and leukotrienes, platelet activating factor, nitric oxide, reactive oxygen species, cytokines, and chemokines. The plasma-derived chemical mediators of inflammation are complement mediators, which are C3A, C3B, and C5A, and coagulation system and kinin system. You should know the source and the action of these chemical mediators. So I have shown you these chemical mediators, its source and action in this table. Let's go to the table. So the chemical mediator histamine is secreted by mast cells, basophils, and platelets. And what does it cause? It causes vasodilation, increased vascular permeability, and endothelial activation. Serotonin is released by platelets and it causes vasodilation and increased vascular permeability. Platelet activating factor is secreted by leukocytes and endothelial cells and it causes vasodilation, increased vascular permeability, leukocyte adhesion, chemotaxis, degranulation, and oxidative burst. The prostaglandins are secreted by the mast cells and leukocytes and they cause vasodilation, pain, and fever. Leukotrienes are secreted by the mast cells and leukocytes and they causes increased vascular permeability, chemotaxis, leukocyte adhesion, and activation. Cytokines like interleukin 1 and TNF are released by the macrophages, lymphocytes, endothelial cells, and mast cells, and they cause local endothelial activation by expression of adhesion molecules, systemic acute phase response in severe infections, and septic shock. The chemokines are secreted by the leukocytes activated macrophages and they cause chemotaxis and leukocyte activation. Reactive oxygen species are secreted by the leukocytes and they cause microbial killing and tissue damage. Nitric oxide is released by the endothelium and the macrophages, which cause vascular smooth muscle relaxation and killing of microbes. Complements, the source is plasma and it causes leukocyte chemotaxis and activation, opsonization, and vasodilation. And the kinins, again the source is plasma and it causes increased vascular permeability, smooth muscle contraction, vasodilation, and pain. To summarize these effects of these chemical mediators, vasodilation is caused by prostaglandins, nitric oxide, and histamine. Increased vascular permeability is caused by vasoactive amines, C3A, C5A, bradykinin, leukotrienes, and VEGF. Chemotaxis is caused by C5A, leukotriene B4, chemokines, interleukin 8, TNF, and bacterial products. Pain is caused by prostaglandins and bradykinins. Tissue damage is caused by neutrophils and macrophage lysosomal enzymes. reactive oxygen species or oxygen metabolites, and nitric oxide. Coming to systemic effects of acute inflammation. Well, the pyrogenic substances are released that stimulate the hypothalamus to increase the body temperature and causes fever. So first systemic effect is fever. Also there is leukocytosis because of interleukin 1 and tumor necrosis factor produce accelerated release of leukocytes from the bone marrow. And there is release of C-reactive protein, which is an acute phase reactant because of liver changes in acute inflammation. What are the morphological patterns of acute inflammation? The morphological patterns of acute inflammation consist of serous inflammation, fibrinous inflammation, suppurative inflammation, hemorrhagic inflammation, catarrhal inflammation, and pseudomembranous inflammation. In serous inflammation, there is exudation of clear fluid. For example, in skin blister, pleural pericardial, or synovial infusions. In fibrinous inflammation, there is exudation of fibrinous fluid. For example, seen in fibrinous meningitis, fibrinous pericarditis, and fibrinous pleuritis. Suppurative inflammation, there is exudation of pus, and the examples are acute appendicitis, acute suppurative lymphadenitis, and acute pyelonephritis. Hemorrhagic inflammation, when hemorrhage is combined with inflammation, and the example is acute hemorrhagic pancreatitis. Catarrhal inflammation is seen when there is exudation of mucus with white blood cells, and the example is acute catarrhal bronchitis or in common cold. And pseudomembranous inflammation, when there is formation of a false epithelium on the mucous membrane composed of fibrin, leukocytes, and necrotic material. Example is pseudomembranous colitis, pseudomembrane in oropharynx by Corynebacterium diphtheria. Sequelae of acute inflammation. Now, once the acute inflammation is done, what can happen? Either it can persist or it can resolve. So, if there is persistence of acute inflammation, it will lead to chronic inflammation, and which will further lead to repair. And if there is resolution of acute inflammation, all the changes which has happened in acute inflammation will gradually reverse. For example, the neutrophils will no longer marginate, the vessel permeability returns to normal, the exudate drains to lymphatics, the fibrin is degraded by the plasmin and other proteases, and neutrophils die, break up, and are carried away or are engulfed, and the damaged tissue may be able to regenerate. So in this lecture, I have told you about the definition, causes, types, signs of inflammation, vascular and cellular phases of inflammation. I have also told you about phagocytosis, the chemical mediators of inflammation, systemic response of body to acute inflammation, morphological patterns of acute inflammation, and the sequelae of acute inflammation. Acute inflammation is a very important topic for your exam. I would like to tell you all that please go back, read the books, come back, see these slides, listen to the lecture, and try to understand the concept of acute inflammation, because it's really a very important topic. I hope this session was useful for you people. Please do subscribe to my channel, and bye-bye for now.